Rajakila is a fantastic, tremendous master from London and very dedicated to everything dealing with the injectables. And today he will focus on the orbital injection. Please, Raj.
Okay, thank you very much. Tatiana, do you want to introduce or are you happy for me to start?
I'm happy if you start.
Okay, perfect. So let's crack on then. I have with me a patient who is 51 years old. Her name is Joelle. Interesting background about her. Her father is Algerian, her mother is Moroccan. So there may well be a degree of genetic or hereditary predisposition to this presentation here. Now,
you like the difficulty, huh?
Oh, well, of course,
I can tell you.
Of course. Interestingly, we injected around 200 patients down in Lyon, in the south of France, and a lot of those patients were coming from Algeria, and so they were presenting with this this medial hollowing. So, interestingly, she says that she had this this issue since she was age 5, and it gradually just got worse through adolescence and then through adulthood. And really what she describes is the perception of her eyes giving the impression that she's sad and tired when she's not. I've just spoken to her and she's a delightful lady, she's very happy. So if we look at the orbit as a 360-degree complex, actually we would like to address all of the 3 quadrants here. Now in the first instance, she's already had botulinum toxin in this central zone here, so we don't need to treat that. Now when we move laterally here, we do want to address the eyebrow. And look, she has a downward turning eyebrow, so this is the first indication. If we now show me a big smile, please. Relax. She has crow's feet. So the crow's feet do lend towards a slight negativity here at the lateral canthus, and that's our second presentation with fillers. Now, if you look to the ceiling, please, thank you. You can see the infraorbital crease very, very clearly here. If we look at the other vector that's causing us sadness is here in the tear trough, and there is a little oblique extension of this that runs through the mid-face, and here the mid-cheek groove. Now if we count these white lines up, we have 1, 2, 3, 4 reasons why Joelle is giving the impression of looking sad. People assume that someone is tired when they have certain projection or elevation in certain areas. The first one is in this malar mound region, and we know that this fluctuates diurnally. It fluctuates from day to day depending on the lifestyle of the patient, and we try and mask the presence of this with our treatment. The second area, of course, is here. Look up for me, please. In the infraorbital fat, we know that this prolapses anteriorly and it gives the eye bag, which makes the patient look more tired. The final area is the nasolabial fat compartment, which gets heavier through aging, and we know that patients look more tired when they have a heavy or a sagging cheek. If we're going to inject the patient, we have to make sure that we're respecting the danger, of course. So let's now work around in a clockwise fashion. Jonathan, that was fabulous and very accurate in terms of the risks, but also the benefits of treating this area. He started by talking about the supratrochlear artery, which comes up through here. Then we have the supraorbital artery, which runs up the forehead like this. Then here we have got 3 vessels of interest. We've got the superficial temporal artery, and then we have the posterior deep and the anterior deep temporal artery. So we have to take care with those. Looking at the lateral part of the midface, the transverse facial artery runs just underneath the zygomatic arch, and then it supplies the midface here. Now moving medially, and look up to the ceiling again, please. Up, thank you. In the medial limbic line, of course, we have the infraorbital foramen, and we would want to try and avoid that. So it's 1 centimeter below the orbital rim. And finally, we've got the facial artery that runs up just lateral to that buccal maxillary retaining ligament, up the nasal wall, and then it disappears here into the orbit. So look, there's a lot of red on that face, but also these blue zones are no-go areas. So how on earth do we devise an injection strategy to cope with all of this potential complication? Well, here we go. Let's begin by looking at the eyebrow. Do we want to lift it medially, centrally, or laterally? We know that that vector is much more attractive. So the eyebrow lifting here in the roof, the retroabicularis fat compartment, is there. Exactly as Jonathan said, just lateral to the temporal fusion line, the temporal injection point is here, and it's within a 1 centimeter square of its union with the orbital crest. Now, if we turn here, there's normally a little notch here or a depression on the zygomatic arch, and that's where we want to place our zygomatic injection. This is hugely upgrading because it lifts the whole of the midface, and it does help with the periorbital area. The next injection will be just anterior to the festoon, not into it because we don't want to make it bigger, and then into the SOOF here, just below the infraorbital crease. Now, if we have a look at the infraorbital crease itself, look up to the ceiling, we have one injection point which is just here, right in the midpupillary line. Then we move to the lateral lid cheek junction, and finally we will then correct the tear trough if there's any depression left, but you've got to take care because the angular artery is running very close there to the medial canthus. So what I'll do is, just for speed, I'm going to move over to the other side, and we'll inject that side for her. Any questions, Tatiana?
Hello, Raj, Tatiana here.
Hello.
That's more than perfect. You have explained everything. And what I must say, this side that you are going to inject now is actually the more difficult one because the patient has a slight asymmetry.
She has it, yeah.
And when I saw the patient for the first time, I thought, wow, this is a really difficult patient.
Yeah, she's difficult, I think, partly because of her hereditary background, but also because of the fact that she has had the toxin in the glabella region, and by comparison, the areas of deficit are relatively worse, and we see that a lot in our patients that present to us. Now, when we turn this way, thank you, we'll just give a little clean. She's already been cleaned, but I always like to make sure that we're not dragging any bacteria in there because we don't want any inflammation. I'll be talking about that first thing tomorrow morning here in room 1. So, the first product that I'm going to use will be something with a high lifting capacity. Of course, we would use something that's a little bit more higher molecular weight on the zygomatic arch. So I identify where this is going to be by feeling for the notch. Jonathan, so I'm going to inject the zygomatic arch about 1 centimeter up from its inferior border as to not inject to the transverse facial artery. So I pull that skin back slightly, and then I'm going to make an injection that's perpendicular and go down to the bone, and I need to find that periosteum. This is my anchor point. As I release, you can see that there's a little bit of entrapment of the skin behind the needle. Make an aspiration for safety, and then now we can make the injection. And look, I'm going to go nice and slow, and I'll inject maybe around 0.2, and I might do a little bit more because she has a little bit of volume loss here in the lateral part of the midface. And anchoring this further back is going to generate lift. It's also going to start the process of improving the infraorbital crease for me.
And
Okay.
Raj, you are staying in contact with the bone all the time when you're injecting.
Always.
Stay like that. So, Jonathan, could you show us what is exactly... No, take out the skin.
Okay.
Take out the skin, Jonathan. Pull up the skin. No, take out the skin, and we
Peel
would
off.
like, we
Peel
would like
off.
to see inside where you are. Yes, perfect. So, yes, exactly. So that's exactly the right vision. Thank you so much. So you can see now the injection is absolutely in attachment with the periosteum and the bone. Okay, let's go.
Back to me?
Yes.
Okay, beautiful. Thanks, Jonathan. So now...
Don't forget to speak a little about the product, Raj.
Okay.
And that's my pleasure to mention that Allergan make a special unrestricted grant for this development about the orbital injections.
So the first injection was Juvidem Voluma, so it's a higher molecular weight product, better viscosity, and of course the optimum lifting capacity. That's my rationale for using that product here. And again, when I go to the eminence of the zygoma here, I'm also going to be using Voluma, but always make sure that you're just anterior to the crest of this malar mound as to not make it worse. So I pull that skin back slightly, hold the underside of the inferior border of that zygoma maxillary junction, pull back, and then I'll be injecting down here and going straight to periosteum.
Okay.
Touch the bone, and then, of course, you make the aspiration for the safety, and then you can make the injection.
And just one short comment. You see, everyone, when we say aspirate, it means really aspirate, pull back the stamp, and not just a little bit of touching, and you see it on the syringe, actually pretty clear what Raj is doing.
You have to see a bubble coming back into the syringe, otherwise it's just a false aspiration, and actually you could be in an artery and not know about it.
Okay, so Jonathan, could you say where we are? Is it the deep fat? Is it the superficial fat? Jonathan?
It's in the deep fat of the midface, in the medial deep fat pad.
Good, good. So please, Raj, go on.
Okay, so exactly as Jonathan said, we're going to continue this injection, and you know the injection plane has really been in the SUF. If we're in the superficial fat, what we may do is we may give a heaviness to that medial compartment, nasolabial compartment, and make the nasolabial fold slightly worse, so that's an absolute no-no. If you look to the ceiling now, thank you, up, thank you. So this demarcates where I'm going to place that product. You see here, it's at the base of the tear trough, at the mid-pupillary line, and I'm going to place this product, which is Juvederm Volif, and I'm going to mold this now superremedially upwards towards the trough. So I go all the way down, very carefully, through the skin, through the muscle, and now through the SUF, and now we are going to touch the bone. It's very important here that you touch the bone. And I go a long way because she has almost a degree of...
Raj,
okay.
that's better. We had your hand in front of
Oh, sorry. She almost has a degree of maxillary hypoplasia, so she's very retruded.
One more time, you know, we have your hand just...
Sorry.
Okay, so please change the camera.
I think that's a better camera angle. That's
Yes.
fine.
Stay like
Perfect.
that. Stay
Okay.
like that.
So very slow injection, very purposeful. And I'm watching for a nice rebound within the base of the tear trough. And I want to take it to an almost full correction, and then I'll manipulate the product slightly and just rotate it a little bit more medially. So what I do with this material now, I'm just going to push it up through the tear trough, and you can see already that
The zoom is too big, so please defocus a little bit.
Raj, can you mention how much did you inject
Let's
so far?
stay on a more defocus vision.
So this is 0.2 cc, and this was just at the base of the tear trough, at the level of the SUF, but I was touching the periosteum all the way. You can see here now that there's a really nice effacement and a better union between the lid and the cheek through here, this transition, and this in itself will make her look more refreshed and less tired as a result. So Jonathan, would you like to explain what we did there?
Yes, so he is going in, the tear trough ligament is the medial extension of the orbital retaining ligament. Medial to the mid-pupillary line, it becomes called the tear trough ligament. That attaches the orbicularis oculi to bone. He is going underneath the orbicularis and getting right on top of the bone in the pre-periosteal area into the deep fat, lifting up that area, sort of detaching the ligament a little bit and lifting up this area, this fat area, to lift up and volumize the concavity of the tear trough.
So the risk in this area now, as I move more medially, is going to be the angular artery. So for me, the number one rule here is to never breach more than 5 millimeters from the medial canthus. If you look upwards, please. Thank you. So the next injection will be placed around here. We go with a needle. I prefer a needle because I know that I'm going to get better precision with a needle as opposed to a cannula. So down through the skin, through the muscle, touch the bone again. And then now I make a very careful, very, very slow and gentle injection. You can see now that there's a better union between those two compartments. And because I'm using a product, Juvederm Volif, that has high degrees of moldability, I can manipulate the product now. So what I can do is I can send it medially and just do the slightest little mold, and I get a much better union between those two structures. So Jonathan, you want to show us that area?
Yeah, so he is down on bone here medially and more superiorly, just trying to stay lateral to where the artery is, and then he's going to come in and mold that area carefully.
Jonathan, can you once again show the artery, just to make clear how far Raj is from the artery?
Well, in order to show where the artery is, we have to lift up this and lift the muscle up, and it's right here on the bone, usually running into the junction between the nose and the face. So the artery is going to be right about in here. But I would have to lift up this muscle to see that.
So this is exactly why I approach with
Lateral
this
to the artery.
with this 5 millimeter rule, and I think that's a really important safety point when you're injecting this very delicate area. Okay, next injection now is for the lateral lid cheek junction. Now look at the effect here of me injecting and lifting this area. If I was to lift the lateral lid cheek junction vertically, I'm giving a slight lateral canthal lift, and indirectly I'm going to make her look like she has a more happy eye. At the moment it's a slightly sad and downturned eye. So I orientate my needle so that, and look up please, thank you, look up, up, thank you. So I orientate my needle so that it's exactly in line with the orbicularis retaining ligament. I then go down and I pull back slightly. I'll go down all the way through and then touch the orbital rim. Once I'm at the orbital rim here, I can then now project the tissue upwards, and it's a little bit like a tower technique, but I stay on the bone. I allow the product to come up and do the work for me. Once I've done that, I've got a little bump, and I'll take that little bump now and then mold that upwards towards the lateral lid cheek junction, and it conforms to the orbital rim beautifully. But in the same process, you see a vertical elevation of the lateral canthus, which is really pleasing to the perception of her mood. This side, she has a slightly downturned lateral canthus, and then this side now she has a much more open canthus, and it gives the impression of, well, I suppose, happiness and contentment. Back to you, Jonathan.
So he is coming through the skin, through the orbicularis oculi, and down on top of the periosteum in all likelihood, might be underneath it, but right onto bone, and making sure, sometimes with another finger, that he's not in the orbit. So I would place a finger at the orbital rim to make sure that my needle or cannula has not violated that. And I'm in this area with the needle, making sure that I don't violate what is the orbital fat, which is inside of the orbit, above the orbital rim. So I'm deep in this area.
Okay, thank you, Jonathan. So now we move to this superior lateral quadrant of the orbit. So we've done the midface, the SUF, the infraorbital crease. She still has a hollowing here in the tear trough, but this is a lot of hyperpigmentation as well. I think this is going to need a different approach, maybe with something that's skin-directed. When we look here at the eyebrow, I'm going to lift the lateral tail of the eyebrow by injecting the temple, but I'm then going to inject here at the apex of the eyebrow to give her a better arch. So the first injection is going to take place here in the temporal fossa. This is the temporal fusion line, and its intersection here with the orbital crest. 1 centimeter up and into the fossa is this spot here, and this is described by Arthur Swift from Canada as being the most optimum spot for brow lifting and also temporal correction. It's also the safest as well. So we feel around this area for any pulsations. You can have a little branch of the superficial temporal artery here, but you're going to be away from the deep temporal vessels. I go down through the skin and then through the layers. So superficial temporal fascia, temporalis muscle, deep temporal fascia, and then we're going to be on the bone and through that deep temporal fat. Here it's important that I make this aspiration. There's the bubble. I'm going to inject nice and slow because the patient sometimes feels pressure here. So nice and slowly, giving a vertical elevation to the lateral tail of the brow. Tatiana, whenever you want to have structure, then we use a higher molecular weight product with better viscosity and lifting capacity. And whenever you want to augment soft tissue, you can step down into something that's more less viscous. I do a slight mold, and we can try and effect more of a brow lift here. So, over to you, Jonathan.
Okay, so I think that we need to save a little bit the time. So, do you want to make a very quick conclusion, Raj?
I'm gonna just make one more injection.
Okay,
just
so very quickly.
Just to frame that eyebrow. You can already see that this is coming up nicely. So I'm gonna inject here, just behind the roof, onto the periosteum, and that's gonna give me an angle improvement here at the brow. So down to the bone, because it's a dangerous area, fix on the bone and aspirate. Then you can make a very small injection, and maybe 0.05 to 0.1. I'm going to use it almost like a glue in this area. So I'm going to stick the orbicularis oculi up onto the product and try and really get that angle of the brow better. So if we have a look at these two eyebrows now and the whole orbital complex, if you just come forward, thank you. Show me a wide angle,
Can we have
please.
the overview picture from the camera
From
again?
the
Yeah,
front.
that's better.
Thank you. So we can see here, if you look at the camera now, please. The left eye, the treated eye, it looks a little bit fresher. She looks a little bit healthier, more rested, but also the vectors are now more upward going. Number 1, number 2, number 3, and number 4. So it makes her look just a little bit happier and more content.
Okay, so a very quick conclusion, Raj, please.
So, I mean, treating the periorbital area is hugely challenging. It's dangerous, and we need to understand exactly what the indication is that drives us to an injection strategy that's safe but effective. So I think we have to respect the area hugely by understanding the anatomy, not trying to give the perfect result, always undercorrect slightly as opposed to overcorrecting, and that way you will try and stay out of trouble. So thank you very much, guys.
Thanks a lot. So could we have a very quick conclusion, Jonathan? Jonathan, about what's the top recommendation you would like to mention?
I agree with Raj entirely. I think we have to avoid vessels, which are the things that are the most dangerous to us, including vision problems. In the glabella, we've got to be careful about necrosis problems so that we avoid any complications. This is a really important thing around the orbit. Having said that, I would say that filler around the orbit tends to be very powerful in a good way, and it also tends to last for very long. It tends to stay longer than it does in other areas of the face. So it's a tricky area, but you can have some very positive, efficacious injections from it and good change in the patient if it's done correctly. Thank you very much.
Thank you both. You have done a great job. I agree with everything you have said. The only thing that I don't agree with, Raj, there is one thing that I always use a cannula in this area because I can go much closer to the medial epicanthus in even correct more difficult cases. But definitely what is the most important thing, when it doesn't matter if you use a cannula, blunt tip cannula, and when I say blunt tip cannula, I mean at least 25G. 30G cannula is like a sharp needle, and 27G cannula can also perforate the vessels if it's a short one and a rigid one. So stay as close to the bone as possible, also with the cannula, and be aware where are the vessels. And what I agree, definitely always undercorrect, and I can say from a very personal experience, filler in the tear trough and the infraorbital area can persist even up to more than 2 years. So if you have complications, they can also persist for more than 2 years. Thank you both.